So I have 3:01 Central Time, so I'm going to go ahead and start. Hi, everybody. I am Maida, your moderator, and I'm going to introduce this wonderful panel. So this session is evidence-based emergency care for transgender and gender diverse children, adolescents, and adults, co-sponsored by the Academy for Diversity and Inclusion in Emergency Medicine and the Academy for Women in Emergency Medicine. And we'll be hearing from three speakers, Dr. Clinton Coyle, Dr. Hannah Janeway, and Dr. Aidan Shapiro. So take it away.
Great, thank you so much for having us here. I'm going to pass it over to my two other co-panelists to give their introductions. So Clint.
Great, hi, I'm Clint Coyle. I'm on the faculty in emergency medicine at Harbor-UCLA Medical Center in Torrance, California. I'm our Associate Medical Director for Quality and Safety, but my side job is I'm also the Director of Transgender Health for the LA County Department of Health Services.
Hi, I'm Aidan Shapiro. I'm at NYU in Bellevue in New York. I'm a first year attending there, and I've had a long-term special interest in LGBT health issues and specifically trans and non-binary health issues, perhaps partially because I am trans.
And yeah, my name is Hannah Janeway. I'm the Ideal Fellow in the Department of Emergency Medicine at UCLA. I've also had a long-term interest in this, partly because I also identify within the community. So we're gonna talk today about evidence-based emergency care for transgender and gender diverse children, adolescents, and adults. We don't have any disclosures, but we might be discussing some treatments that are off-label, but are supported by international treatment guidelines. So our objectives are, we're going to summarize the terminology and health concerns surrounding transgender and gender diverse individuals, and then describe some barriers to effective healthcare that they experience, and then provide you guys with an effective approach to emergency care for these individuals from childhood through adulthood, and cite some benefits and complications of gender affirming therapies. So why does this matter? I wish I didn't have to put this slide up still, but unfortunately I do, because I think it's super important. This is a study from Canada, from Ontario, Canada, where they surveyed transgender individuals, 408 of them, and they found that 21% of individuals actively avoided the emergency department because of their gender identity. And only 33% reported ever using the ED in their felt gender. Now that might be for a number of reasons, but does say something about whether people feel comfortable presenting to the emergency department in their felt gender. In addition, that study documented that there are a lot of trans-specific negative ED experiences that they had. 52% said that they had some sort of negative experience, including 10% who said that they were refused care, 32% who were experienced hurtful or insulting language, so 1/3. 31% who were just told by the provider, you know, I don't know enough to provide care for you. And 12% who had providers who refused to examine parts of their body. About half of them said that they had to educate the ED provider either a lot or some about their medical condition, which is unacceptable. We don't ask the same of our patients who have cardiac problems or pulmonary issues. So we really need to educate ourselves better to provide adequate care. These are some quotes from two qualitative studies, and if you're going to read anything, I recommend that, because that's actual words coming out of individuals who've had experiences in the emergency department and who are trans and gender diverse. But they're pretty concerning, right? So I revealed my status, which no one usually knows until I tell them, and then things got weird. The doctors were rude, barely treated me, and tried to get me out of there as quickly as possible. And worst of all, when I tried to use the women's restroom before I left, they threatened to call security on me. It was humiliating, and I would die before I ever went back there again. It seems like we have to educate them all the time and be very patient, very patient. And, you know, they're whispering, is that the right person? Who are we looking for? We're looking for this person. And then they start calling me by my female name. And I'm like, I'm not female, I'm male. So I think these really demonstrate that these issues are active. These are all recent studies, and that we have a lot of work to do in the emergency department. A national study that was done in 2011 that looks at all sorts of barriers for transgender and gender diverse individuals found very similar results to the Ontario study. 20% said they were just straight up refused medical care. And there was about 1/3 who postponed medical care due to discrimination. The study also reported a lot of barriers and social inequities that transgender and gender diverse people experience. As you can see, 19%, which is very high, reported experiencing homelessness, and about 60% reported experiencing significant familial rejection. This comes from a study that looked at what providers think they know and what they actually know. And what this study shows is that while we think we know what we're doing, we actually might not. So they tested knowledge and attitudes about transgender and gender diverse care, and it showed that only 10 to 25%, depending on the question, of people were able to get very basic questions about transgender care correct. And that's despite the fact that 62% of them said that they actually had received formal training. So A, there's not good enough formal training, and B, the formal training that there isn't sufficient to teach them everything they need to know in order to provide adequate care. The last is about attitudes, about whether they feel comfortable asking about which personal pronouns a transgender or gender nonconforming person uses. Most said that they felt comfortable. However, if you look at the data and the qualitative research studies and along the way, it'll show that despite this comfort, very commonly, or feeling comfortable, very commonly, providers do not ask individuals how they would like to be referred to or what pronouns that they use. So I'm just going to start, kind of going into the treatment or kind of framework part by just starting with some just really basic things that I think are super important to mention before we mention anything else. So first, transgender and gender diverse TGD, that refers to a large range of gender diversity. Transgender individuals are not mentally ill. While DSM-4 said that classified transgender and non-binary individuals as having gender identity disorder, that was later replaced in DSM-5 as gender dysphoria. And WPATH and other large health organizations have argued for the complete, deep psychopathologization of transgender identity completely, which is also the stance that I take. Gender exploration can take many forms, and gender-affirming interventions may or may not be necessary at different stages of development to help children, adolescents, and adults feel more aligned with their gender identity. There is no one pathway or manner to be transgender or gender diverse. And I think this is the most important thing that I'll say, just because I've seen people project a lot onto other individuals, so project their own stereotypes or what they think they know about transgender and gender diverse individuals onto the patient. There isn't this thing where you're born and given a sex assigned at birth, and then you do a bunch of steps, and then you're this other, person or have another gender identity because you went through those steps. Everyone's journey is unique and different. There's no cookie cutter model. Some people might do some aspects of gender affirmation, and others might not do any at all, and that does not make them any less transgender or gender diverse. So just be really careful, because that's literally, for a lot of the micro macro aggressions that I have heard about from colleagues or from patients, that is probably the root of where a lot of those micro and macro aggressions are coming from. This is the gender unicorn. It replaced the gender gingerbread person because the gender gingerbread person illustrated a very Western gender binary, which is now rejected by the community at large. And it shows that you're assigned sex at birth, and then you can fall anywhere along this spectrum of gender identity, gender expression. And there is not just male and female, but there's also this other gender that people experience or identify with that may or may not be less or more common in different cultures and different places. So it's just try to get the whole gender binary completely out of your head. And that is distinct to who you're physically attracted to or who you're emotionally attracted to. A note just about children and adolescents. One study showed that it was a study of children up to age 21, and they showed that the mean age in which individuals identified as transgender or gender diverse was about 13 plus or minus 4 years, but the range was really, really large. There were some people as young as toddlers, 2 to 3 years of age, and some people up to 20, because that's where the study ended, who were just then recognizing themselves as transgender, and that can go out through the rest of adulthood. Gender affirmation can take a variety of different steps or different aspects of gender affirmation. There's social affirmation, which is just affirming one's gender through name, pronoun use, and outward expression. There's legal affirmation, where you kind of legalize your name or other parts of your identity. And then there's medical affirmation and surgical affirmation, which involve using medications or surgeries. These are some basic terminologies to use or to not use when discussing transgender or gender diverse individuals. Now, I'm going to go through this, and this is kind of like the standard right now. Things might change and things have changed. And your responsibility is just to know what sort of language to use in your documentation and to referring to the community and to individuals. But I just want to be really clear that at the end of the day, if a patient is using one of these words on the don't use list, it's fine to use that word in relationship with that person. You should use whatever language the person uses and pair it back to them. So if they say, I had a sex change, it's fine to say, okay, when you had your sex change, that's perfectly acceptable. But in general, those are terms you want to avoid. The reason why you want to avoid male to female, female to male, and I see this a lot, and Aiden might touch on this later, is just because that kind of goes back to this assumption that you're born male, which transgender females do not feel like they were born male, they feel like they were born female, and then somehow they transitioned to the female gender identity. No, they have always been female, and through the course of their life, they've been able to come closer to being able to express themselves in their felt gender, and it's really important, therefore, to not kind of legitimize those stereotypes. Transgender, gender diverse is becoming more common than transgender non-binary, only because the gender diverse identity is more than just non-binary individuals. Some identify as gender queer or non-conforming, and so that's why that term has changed slightly. A note on pronouns. So if you look there at table 2, this came from a study from 2019 that looked at the major discordance between patient and provider perspectives on asking people about their sexual orientation and their gender identity, including pronoun use. On the provider perspective, you can see that there was a lot of hesitation by providers to ask this information because they felt like maybe it wasn't relevant or they didn't want to offend people. Whereas on the other hand, in the patients reported, and this included cisgender, heterosexual patients as well, they reported that they felt like they would like to be asked, what their pronouns are, how they want to be referred, and questions about their sexual orientation, because it facilitated better patient-provider rapport, and it was crucial for individual patient-centered care. So I would encourage everyone, and especially with children and adolescents, to ask people's pronouns and how they would like to be referred to. We don't say preferred pronouns because people have pronouns, and the pronouns that transgender and gender diverse people have are not their preferred pronouns, they are their pronouns. And so that's why preferred pronouns is not used. For teens and children, you should ask at the beginning of the encounter and when the parent steps out of the room, when you do your normal kind of exam with teenagers. But that said, if they disclose to you their gender identity, which is different than what they said in front of their parent, please do not out these teens to their parents. I know you might think that you're doing something that would be helpful or trying to bring that, those two people closer together, but the reality is, as been shown by lots of data, is that a large number of transgender, gender diverse individuals experience violence at home secondary to their gender identity. Actually, it was 10%, I think, from the National Transgender Study who reported that a family member was violent to them because of this, and 8% were kicked out of their home. So if you disclose this, you could lead to harm to the patient. And it's important to inform others on the treatment team, only because other people on the treatment team need to know how to refer to the patient, but you don't need to tell everyone in the emergency department. This isn't like an overhead announcement or telling tons of people who don't really need to know, just people who are going to be interacting with the patient and need to know whatever information they need to know in order to communicate with the patient. And this little sandcastle, this is actually from Aiden. This is Tiger Danny or Daniel, and he uses mostly they, them pronouns. So if you're having problems remembering how to correctly use gender neutral pronouns, or you make comments about how difficult it is for you, which by the way is a microaggression towards non-binary and gender diverse individuals, you can just go and do a little bit of learning on PBS and learn what the children are learning right now.
All right, so I think we're gonna switch over to my section. So, now we're gonna sort of move a little bit in towards how to take a physical and history with some of your trans and gender diverse patients. So, we've been sort of hammering this home, but it's really important to ask people their name and pronouns. I get that people have anxiety about doing this. They don't want to ask the 90-year-old grandma what her pronouns are. I will be honest, I don't ask every ankle dislocation what their pronouns are before I reduce their ankle, right? Like, it isn't always an emergency. But when I do, I always offer my pronouns first, which I think is a really important tip. You know, so you sort of walk in and say, hi, I'm Aiden Shapiro. I use he, him pronouns. Do you have a preferred name that I would use, and what pronouns do you use? And I think we could all do it more than we are currently doing, right? I think I do this for everybody that is, I might be identifying as LGBT. I do this for anybody that I'm going to have a sort of a sensitive conversation with. I think of it in my mind as like anybody that I'm sitting down next to like, we're having a conversation. That's sort of my moment when this sort of like as a trigger for me to remember that this is something that I should probably introduce as part of the conversation if I'm trying to create like a safe space with this patient. I think it's also really important, and I think Hannah touched on this as well, using language that people use about themselves. You know, we use clinical language in most of what we do, and that's fine. But if a patient uses different terminology to refer to their body, then I think it's important that we mirror that. And it's important to sort of reiterate to patients why you need to ask questions, right? You're not being nosy, you have a reason for why you're asking this. And when you do so, you're asking it in a non-gendered way, right? So this is my last bullet, so take gender out of where it doesn't belong. Bathrooms don't have genders, body parts don't have genders. I mean, this isn't really like a clinical language that we would use, but there's no such thing as girl parts and boy parts. There's just body parts, and people have gender. So next slide. So, you know, some of the important information that you have to get at is, you know, are asking people a sexual history, you know, asking what sex were you assigned at birth? Have you made changes to your body to express your gender? And have you taken any hormones or medications related to your gender? Have you had surgeries to align your body with your gender? Are you sexually active? You know, I think in med school, a lot of us learn, do you have sex with men, women, or both? That's really out of fashion these days. I would say we can be a lot more descriptive than that, right? I think you can say, what gender are your partners? What gender is your partner? Can you describe the gender of your partners? And you know, these are important questions, right? These are questions that affect your differential, right? They can affect what's going on with your patient, and you need to start establishing what we would call an organ inventory. You know, you need to know if somebody has a uterus or a prostate or ovaries or testicles, because it just affects the differential that you're going to create. So next slide. Another really important tip when you're taking a history from some of your trans and gender diverse patients is important to sort of think about things that are important in a social history. You know, again, not true of every patient every time, but especially with your trans and gender diverse patients, they have often decreased access to care. So it's one way to think about this is taking this as an opportunity, right? This person has overcome whatever barriers they needed to come to get to you today. And so it actually is a really good, useful opportunity to sort of link them to care. If they need other sort of non-medical supportive services, this is an opportunity to get them linked into those things. So asking about housing, poverty, employment, intimate partner violence, all of those things, because there are increased rates in this population. So it's important to sort of make sure you're flagging that. Go ahead, next. And you know, when we want to use open-ended questions, right? This is something that I think is like a really useful learning point with all of our patients. You don't have to be talking to an LGBT person to make this kind of a mistake, but I think it does happen more with LGBT patients, right? I think a lot of women go to an appointment with their wife and somebody asks if it's their sister, and that happens way more often than it does with cisgender and heterosexual couples. So click next. You know, I think this is my favorite phrase that I have learned in terms of taking a medical history. How are you two connected? Sometimes I say, how are you two related? But then like younger people there with their boyfriend, they get kind of weirded out because they think I'm suggesting that they are biologically related. So I've switched to connected, but that's a great one. Who did you bring with you today is also useful, but just keeping things open-ended and not sort of judgmental. Go ahead. Yeah, just want to avoid things like this. You can keep clicking through the next ones. Right, we talked about this, right? Like you can definitely do better than do you have sex with men, women, or both. There's a lot more options, and you don't need to sort of like put your assumptions on the patient. And then we touched on this as well, not assuming that somebody's out to their family or visitors. This is true of many health conditions and health statuses. You know, some of our patients are under the age of 18, and there are some things that we have to disclose to their patient. Gender identity is certainly not one of them, nor is sexual orientation. And with our adult patients, there's really no excuse for outing your patients in a variety of ways. Go ahead. Yeah, and we talked about this a little bit. So I want to touch on documentation. I think this is something that I haven't seen in a lot of other sort of LGBT and trans and gender diverse talks, is how do we document these patients? These are all things that I've seen, right? These are all versions of the same chart that I've seen. And I think it's like, there's not like an official right answer, but I think some of these are more wrong than others. You know, I think I would probably use the last one. 34-year-old trans male, no significant past medical history with right lower quadrant pain. I think saying 34-year-old female with a past medical history of trans, that's wrong, right? Like you're setting yourself and your colleagues up for failure there, right? The purpose of your note is to communicate with your colleagues how they should be thinking about this person, right? You're sort of trying to frame this patient for other people. It's also worth noting that like more and more our patients are going to be reading our notes, so you would not want them to be offended by what they read there. So, you know, I think the middle one, 34-year-old male, no significant past medical history, not incorrect. If they're there for an ankle sprain, probably adequate. But if you want to give your colleagues a heads up that this person has perhaps different internal organs than they might expect, I think it's reasonable to include that they're trans in your one-liner. And we talked about the sort of the problems with this FTM language, which I think is the most common way that I see this written. And it makes me a little uncomfortable. I think it's framing this in a way that I think our patients would not agree with. A lot of people in the trans community will use the phrase AFAB, assigned female at birth, which is pretty clinical and communicates a lot of useful information to us as providers. But I don't see it written that often. I think it just like hasn't really penetrated the medical community yet. I think that would be like correct. But if the purpose is to communicate information to your colleagues, if it's not a useful acronym if they don't know what it means. So, you know, I think those are sort of the top and the bottom are sort of the options that I would most commonly use. Go ahead, next. So as a case studies, you can click through, I think there's like 2 or 3 bullet points more. So, you know, go back. So if you have a 44-year-old non-binary person in the emergency room with right upper quadrant pain, you know, this history sounds sort of like cholelithiasis, biliary colic, but it's really important to think about, you know, we always want to keep a broad differential, and other internal organs would really affect that differential, right? So you want to know if this person has ovaries or testicles or neither. You want to know if this person has a prostate or a uterus, if they've had internal surgeries that could put them at risk for an SBO. All of those things are really important, and they're going to affect your differential. So go ahead to the next one. So when you ask these questions, which in order to provide adequate care, you really do need to ask. It's important to be clear why you're asking. You know, I think a lot of trans and gender diverse people report that they feel sort of like people are sort of interrogating them needlessly, right? That you're sort of asking a lot of random questions, which you shouldn't do. But you should ask the questions that you need to ask, and you should just be upfront about why you're asking. You know, say, I'm asking because anybody that has a uterus, I need to make sure that they're not pregnant. You can say, I need to know what organs there are inside your body so that I can think about what could be going wrong here. You know, anybody that has a prostate, you should check if they have a UTI, you should check for prostatitis because you want to make sure you're giving them the correct duration of antibiotics. All of those things are important to be aware of. Go ahead, next. Oh, okay. Yeah, and then, you know, I've seen this less, but I have heard of this, you know, somebody coming in with a unrelated complaint, and then all of a sudden there are 10 medical students surrounding their bed and asking to do a pelvic exam. Clearly that's inappropriate. I don't think I really need to go into why, but in general, trying to support your patients. And yes, often we work in teaching and learning environments, but doing that in a respectful way. So there are also specifically trans and gender diverse like issues that I think it's important for providers to be aware of, right? So let's say you have a 46-year-old trans gentleman with bilateral breast pain. And when you do a physical exam, you show like a symmetrical skin breakdown on the chest wall. Go ahead next. Yeah, so one of the big things we're going to talk about is sort of non-surgical body modifications that some trans and gender diverse people will do. So this is referred to as binding. You can go next. So there's a couple of different types of non-surgical body modification. We're going to go through mostly binding and tucking, which is sort of the most common. But quickly, you know, padding and stuffing are sort of the same thing, just sort of like putting padding or stuffing in locations to sort of create a silhouette that aligns better with your gender. Packing is usually when masculine identified individuals will put either like a prosthetic like urinal device or just like a prosthetic penis device to sort of create a bulge in their pants. Let's go ahead next. And then I think later Clint is going to get into some of the pumping issues. So binding is super common. 87% of trans men in one study reported that they bound at some point during their life. You know, basically it's just compressing the breast tissue to give yourself a masculine silhouette. And studies have reported that this is really helpful in terms of mood and gender dysphoria. There are a lot of different ways to bind. There are these great binders that you can buy that will sort of compress the tissue in like a safe and more comfortable way. It's sort of like a very compressive sports bra, but they are kind of expensive. They're like $40 to $80. So some of your younger patients, some of your more marginalized patients may not be able to get them. There actually are foundations that will send these for free to some of your patients, so you can get them connected to that if that's an issue. But some people will bind with ACE bandages or even saran wrap, and that can be more harmful. So go ahead next. So the most common is like skin and tissue concerns, like just like skin breakdown from sort of heat rash, basically. But a lot of people have back pain, heat, chest pain, shortness of breath. And then more rare things can happen, like atelectasis, pneumonia, and even rib fractures have been reported. Again, because of barriers to care, it's really rare that people are coming in for this. But I've had a couple of patients that have come in with this. And really, this is about shared decision making, right? This isn't like you shouldn't do this, it's bad for your health, right? Like it's actually good for people's mental health, right? And I think we need to keep that in mind, right? You're never gonna succeed with patients if you're telling them not to transition, right? But we need to figure out ways to do shared decision making and do this in a safe way so people can take days off. It's important that people spend at least an hour or two out of binding every day. Don't sleep in it. Stuff like that is helpful. Okay, next. And then I think this is my last slide, but another really common thing is that a lot of people on the trans feminine end of the spectrum will do something called tucking. I think this picture sort of says it all, but basically you're tucking the penis backwards, and some people will also sort of insert the testicles back up the inguinal canal. Again, similar to binding, it's just sort of to create a silhouette of your body that makes you have less dysphoria. For some people, this is also really important in terms of safety, right? Like if you're working in the like sex industry, it's really, sometimes people can feel unsafe if they're not passing. But that being said, so that, you know, this can lead to increased risk for UTI or prostatitis or candida. But that being said, if somebody comes in with testicular pain, it's still important to rule out other causes of testicular pain. Like this isn't the only thing that could happen. All right.
All right, thanks, Aiden. So I'm going to cover in the last part of this presentation, we're going to talk about more detail about some of the medical and surgical therapies that can help someone align their body to their gender identity. First, we're talking about injection of silicone, and actually we talked about, this makes it sound like the injection has no silicone in it, but it's actually the opposite. This is free injection of silicone. This is an option that's a lot less expensive than traditional surgery and can help change the contour of someone's body. However, there can be a lot of complications from this, and they're listed here on the slide, including rarely silicone pulmonary embolism. And these can be very serious. These can happen both at the time of the injection, someone can get an inadvertent entry to the vascular system, but these also could happen much, much later, years later, when the silicone migrates. And so this is generally not a recommended treatment, but occasionally this is done outside medical supervision. It's a practice that members of the trans community refer to as pumping. And so you may have patients that come in with this presentation. Next. So let's look at an example of a case and consider how gender affirming care affects this. So 30-year-old transgender woman presents with 1 day of flank pain. Next. Could this be ovarian torsion? So this is, again, kind of changing your perceptions here. The first thing you think of when you hear transgender woman is that, oh, this means this person's a woman, they must have an ovary or a uterus and ovaries. And yet when we talk about transgender woman, usually we're talking about someone who was assigned male at birth. So this is probably someone who has never had ovaries, never had a uterus. It is impossible for this person to have ovarian torsion. Next bullet. But could it be testicular torsion? Well, this is where it starts becoming important then to ask that surgical history and that pelvic organ inventory. So for every patient, once they identify to you that they're a trans woman, you don't necessarily need to know exactly what's going on with their genitalia if their complaint is they have a dislocated shoulder. But if the complaint is flank pain, then you need to explain to the patient, well, I need to know a little bit more, pain in your flank could be coming from testes. I need to know, have you had any surgery on your genitals? Have you made any changes to your body to align to your gender? Next. The patient discloses that they have had gender affirming surgery, and they actually use intermittent catheterization due to a neurogenic bladder. So now you're thinking more about pyelonephritis. The question is, could this be prostatitis? If this patient has had their testes removed and has a neovagina from a vaginoplasty, do they still have a prostate or not? And so having a little bit of knowledge about what these surgeries are, the answer is yes. Generally, with a vaginoplasty, someone who was assigned male at birth will have their testes removed, have their penis modified, and have creation of a neovagina, but usually the prostate is not manipulated at all in that procedure. It may change location slightly, and it may actually be easier to examine through the neovagina than through the anus where we would normally examine. In any case, let's go to the next slide. That was just an example. So what are some of the medical therapies? Well, first of all, starting with adolescents, puberty blockers, GnRH analogs, are extremely important. These are medications we've been using to treat precocious puberty for a very long time. A child that's starting to enter puberty early, when they take this exogenous GnRH, it blocks the puberty process and delays it. For a transgender adolescent, you could imagine that if someone had been identifying female throughout elementary school and middle school, and now suddenly is faced with going through a male puberty, or vice versa, this could be very traumatic. And so being able to block and at least delay or potentially prevent going through puberty in the wrong gender can be very, very important for that person's overall gender affirmation, and potentially will affect this person's body for the rest of their life, and could be a really important thing for them to do. The most common side effects of these GnRH analogs in transmasculine adolescents were hot flashes, and there weren't any really significant complications reported for overall for transmasculine or transfeminine patients. So you may hear about this from patients. Some adolescents, after delaying or preventing puberty in the wrong gender, will later decide to take hormones to masculinize or feminize their body and actually go through puberty in their identified gender. And that's the puberty blockers. These are probably reversible changes. And a lot of times people are wondering, we're talking about a teenager, maybe they're not sure, something like that. In general, if an adolescent tells us their gender identity, in general, usually people are pretty sure about this, and you can trust what the adolescent patient's telling you. But if anyone's ever uneasy about this, potentially these are reversible changes to simply delay the puberty. But once someone starts gender affirming hormones, that tends to create some irreversible changes in the person's body. But again, these are the changes that match this person's gender, and these are the changes this person would want to have. Next slide. So for feminizing hormones, there's a combination of estrogens. They can be taken orally, they can be injected, they can be transdermal. Older hormones had a few more side effects from them, but modern hormone therapy is generally relatively safe. We'll look at side effects on the next slide. In addition, though, we're talking about individuals who are born with testicles. And so as long as that person has testicles, they're going to be making their own testosterone. And the testosterone can really counteract the effect of the exogenous feminizing hormones. And so a lot of patients need to take testosterone blockers, anti-androgens, spironolactone, finasteride, and others. And so you may see a combination of these elements. If a patient has had an orchiectomy to remove their testes, they probably don't require these testosterone blockers anymore, and they may not require as much estrogen. Next. These have multiple effects, and we can click through these: softening of the skin, changes in body hair, redistribution of body fat, breast development, decreased muscle mass, decreased or loss of erection or ejaculation, shrinkage of the testes, decreased sperm production. There may be side effects. VTE is a controversial one. We know that if somebody who has ovaries and has a baseline level of estrogens takes extra estrogens or progesterones to prevent pregnancy for contraception, we know that increases risk of VTE. But someone who has a low level of estrogen and tries to achieve a physiologic level of estrogen through gender-affirming hormones, that physiologic level may actually not increase your risk of VTE. Hypertension and transaminitis are other possible side effects. Next. For masculizing hormones, we have injected testosterone, transdermal. We have the 5-alpha reductase inhibitors. This, paradoxically, what can happen is someone can start taking masculizing hormones and actually experience so-called male pattern baldness as a result. So you may actually see people on a little bit of finasteride for that purpose. Next slide. Effects: increased facial or body hair, increased muscle mass, scalp hair loss, body fat redistribution, cessation of menses, clitoral enlargement, voice deepening, vaginal atrophy. Side effects can include hyperlipidemia, polycythemia. Again, question about VTE, we're not really sure. This idea of the so-called roid rage that we heard about with anabolic steroid use, whether there's actual behavior changes is controversial, but acne is possible. So for both the masculizing and feminizing hormones, when you work with transgender individuals, you realize these have a strong effect on our bodies. People's bodies are very similar prior to puberty. And when you introduce hormones that match the person's gender identity, it can really align that person's body to that gender identity and make strong changes in the person's appearance, which is what the person desires. Next. A little bit about surgeries. People, when they think about transgender and surgeries, the first thing their mind goes through is surgery on the genitalia. And yet that is relatively uncommon compared to a lot of other surgeries. There's a lot of people where the most important thing for their gender expression and their gender identity is how they present, the name they use, the pronouns they use, their appearance for people, how they dress. Those are the most important parts. And many people really have no interest in changing the external genitalia that they were born with. But for a few people, that's really important. And so you'll see a range. And so it's important not to make an assumption that every transgender person either has had genital reconstruction or is wanting genital reconstruction and hoping someday type of thing. It's something that some people will choose to do and some people will not. In any case, if we look at the upper left, for a transgender man, there's non-genital, non-breast surgeries like voice surgery, liposuction, lipofilling, pectoral implants, the so-called top surgery, which could be breast or chest surgery. You could have a subcutaneous mastectomy, creation of a male chest contour. We'll look at an example of that in a second. Bottom surgery, this is your general surgery, could be hysterectomy or oophorectomy, reconstruction of a fixed part of the urethra, metoidioplasty or phalloplasty. Phalloplasty is creation of a neophallus. Metoidioplasty is a smaller surgery where the clitoris, which is usually enlarged somewhat from the masculizing hormones, then has the suspensory ligament released, creating a larger clitoris and sort of a partial neophallus that way. It's a smaller, less risky surgery, and some people are very happy with that result. Vaginectomy and scrotoplasty. I will mention that one thing about phalloplasty is it's actually very difficult to create a functional patent urethra in the neophallus. And so some patients achieve that, but some do not. And you may see a patient with a neophallus, but what's called a perineal urostomy. So a small opening at the base of the neophallus, and that's where they urinate. And if someone needed to be catheterized, the catheter would be placed into that orifice. For trans women on the right, again, we have non-genital, non-breast surgical interventions like facial feminization, voice surgery, thyroid cartilage reduction, liposuction, lipofilling, gluteal augmentation. We have the so-called top surgery, which is slang for the breast or chest surgery, augmentation, and again, bottom surgery. You can have penectomy, orchiectomy, vaginoplasty, clitoroplasty, and vulvoplasty. Orchiectomy alone is actually not uncommon. Again, people that are taking feminizing hormones may wish to have the testes removed so they don't have to compete with that testosterone. And some patients are fine with having a penis and no testes. Others will actually have prosthetic testes placed so that they have both a penis and testes. But that's not uncommon. Usually people don't undergo a penectomy unless it is part of a vaginoplasty, so creating a neovagina. The whole point of all of this, what you need to know, the takeaways, emergency physicians, is there's a range of surgeries people have. Don't assume what surgery someone has had just because they disclose their identity, and don't assume that every patient wants every surgery, and never tell a patient they're not really trans yet until they've had a particular surgery. And that's actually literally something in qualitative studies that trans people tell us that doctors have told them before. Next, we have a couple pictures. This is a gentleman who's a transgender athlete, Schuler Baylor. He's a competitive collegiate swimmer in the NCAA. I'm sharing pictures that he has chosen to share publicly that show some of his body contour prior to chest surgery, and then shows after how he's been able to create a masculine chest contour through surgery. This is another person that's a really prominent writer, and her name is jumping out of my head.
Janet Mock.
Janet Mock, that's right. So Janet Mock is an author. She's somewhat well known because she had a famous interview with a newscaster that didn't go so well a few years ago and got a lot of attention. But the whole point is, I want to divert your attention away from the general procedures and emphasize that there's lots of people do to create a body that aligns with their gender identity. Next. All right, this is a little bit of a confusing table, but the point here is what it shows is the relationship between gender-affirming care and well-being of the patient. Many people will ask, they'll say, well, this is fine. Someone has a gender identity. It's not matching their sex assigned at birth, but why can't someone just accept that and just kind of go through their life in the wrong gender and just get over it? The fact is that when we provide gender-affirming treatment, in general, people do better. And if we listen to the patient that's telling us, my identity is male, my identity is female, my identity is non-binary or fluid, whatever it is, when we listen to that and we help them align their body, they do better. The top statistics are about a depression and anxiety scale. And what it shows at the top, it's a little confusing, but there's those 1.00 as the reference range at the top. These are people that what they call definitive bottom surgery. That they're, as the reference, they have a 100% chance of having the baseline level of depression and anxiety. As you go down and you look at people who have had no treatment or only a few treatments, their rate of depression and anxiety goes up as you go down the table. And same thing for an anxiety scale at the bottom. In one case, comparing people who have had bottom surgery to people who have had no treatment at all, 4 times greater rate of anxiety, a clinically significant anxiety. So the point is, when we provide these treatments for patients, we're helping them. Next slide. Complications is the same as any other surgery: bleeding, infection, damage to adjacent structures. So if you see a patient having complications of surgery, you would treat these the same way as any other complication. You would examine the area, you would contact the surgeon involved, you would treat infections with antibiotics, possible other procedures and so forth. But really, there's not very much special about these procedures. I mentioned a little bit about the urethra and so forth, but that's what to keep in mind. Next. As Dr. Janeway mentioned earlier, being gender diverse is not a mental illness. There are increased rates of anxiety and depression. These are believed to be more related to other people's reactions than the actual problem with the gender diverse person themselves. Previously known as gender identity disorder, that has been dropped. The newer term in the DSM-5 is gender dysphoria, but not everyone is upset about their gender identity. Not everyone experiences gender dysphoria. So the newer term that's going to be coming out in ICD 11 or 12 is going to be gender incongruence. We're trying to get more neutral about this and not pathologizing everybody's identity. Next. So in summary, transgender and gender diverse individuals represent a diverse group of people. There's no one way to be transgender or gender diverse. There's a significant barriers to health and health inequities. Providers, it's our duty to educate ourselves. We should know something about this so that we're ready for the patient that arrives. If you're really not sure about something, asking the patient what they've experienced or what's happening with their body is appropriate, but you got to have some baseline knowledge first. Don't out children or adolescents to their parents. There are some complications associated with these therapies. Shared decision-making is the best approach. Complications of surgeries are similar to other surgeries, and for children and adolescents, it's important to familiarize yourself with pathways for referral. There's lots of support and assistance out there, and that's all we have for today. We're going to leave some time for questions or comments.
Thank you so much. I would love to jump in and get your response to those states and those political leaders who have decided to kind of weigh in and insert themselves into a really private discussion and matter between a child, a parent, and caretakers. So, for example, the recent law in Arkansas. And I'm just wondering if there is a role for members of IDEM to take to social media or to other forms of advocacy to kind of get information out and to really advocate for in this issue.
I think we're, we tried to take kind of a non-political approach to this, and there's a range of opinions, and I know even among emergency physicians, there's a range of opinions about this. We really want to emphasize how important it is to give the right care to the patient in front of you. Having said that, I think in general, I don't think it's too great a stretch to say that, we want patients to be able to access care. Care really is about decisions between the patient, the provider, in the case of children, the patient, their parent or guardian or care provider, and the provider to make decisions about what's available and so forth. So I think that's probably a reasonable general position.
Mm-hmm.
I don't know, Dr. Janeway or Dr. Shapiro, do you have anything to add?
I think I do think it's like an inspiring time in terms of physician advocacy, right? I think like trans and gender diverse people are much more visible than they ever have been, which I think provides us with opportunities to improve our care and like has made us vulnerable to pushback from a conservative like part of the country as well. And that's sort of inevitable, but I think it like the opportunity is that it allows us to be strong advocates. It sort of allows us to get much better at this and to help where we are able to. I mean, I think like, yeah, clearly I don't agree with the laws in Arkansas, but it's not like I'm not the governor of Arkansas, so I have very little power there. I think, yeah, I do think there's a role for medical organizations to weigh in and say, like, this is not medically appropriate, right? Like, I think this is our lane to say, this is supported by data. This is in the best interest of keeping our children healthy, right? I think there's definitely a role there.
I think it's true as I reflect on this, as I hear people debating this issue, I just hear so many people talking in this space that have no idea what they're talking about. It's funny how this tends to be an issue where when someone first hears this, for some reason their sense is that they know all about it and that they have a lot to say about it because they know. And yet the things I hear people say about what the treatments even are and how gender identity works are just so off base. And so definitely I think we can have a role as educators as well for adding some facts to the conversation.
You're muted, Hannah.
We have one person in the chat who asked for a copy of the presentation, and my understanding was that all of these presentations are recorded.
They are.
Excellent. Okay.
Yeah, we're always happy to share.
Yeah, we're happy to share it, and I agree with Clint and Aiden. I mean, I think medically and also morally and ethically, like as physicians, we do have some responsibility to fight against these laws that are going to create poor health outcomes. I mean, that's what this is going to do. And that's what it's going to do in England, and that's what's going to do in each of these states. And so, as Aiden appropriately pointed out, like this is our lane to say, these changes to the law will create poor health. And, as physicians, we can testify to that with data.
Thank you. I don't see other questions besides that. I just wanted to ask one more, and that was probably about 2 years ago now, having a patient who was a 12-year-old gender expression male, so a trans male child, with a family that was just getting plugged into a transgender clinic, a gender development clinic at a local children's hospital. And this was pre-COVID, so the child was with both parents, and mom was using they, them pronouns. Dad was using gender assigned at birth pronouns, she, and the child was closed off, not making contact. And clearly I was right in the middle of turmoil with parents really struggling with that adjustment. And I made a decision to, in a way, sort of turn away from the parents and just ask the child, what are your pronouns? And it was a pretty profound impact. The child immediately looked at me and there was relief on his face. And it was my first experience with that. And I was wondering, when you are inserted into the middle of that kind of conflict, what strategy you use? And is it as simple as just focus on the patient?
Yeah, I mean, I've been in scenarios like that a couple of times where the patient is using different pronouns than their parent or guardian. I think you have to sort of treat each case individually. Like I this is definitely one of those scenarios where I try to talk to the teen like separately and say, what are your pronouns? I think that's kind of a question you can ask in front of the parents, but I would also probably try to ask away from the parents, and then follow-up question, and what pronouns do you want me to use when your parents are in the room? Like, I think it's as simple as saying, is it helpful for me to reinforce this pronoun that they're not using? Or do you not want me to get into it? Like, is it easier? Do you want me to just avoid using any pronouns altogether? Like, I can just use,
right.
I can just use your name every single time if you want, like, so you really have to, I think, just ask the patient in privacy, like what they want. And that's, yeah.
Thank you. And can I ask you, since both you're all on different coasts, how did the three of you connect for the presentation? Did you know each other from academy work?
I knew Clint from, he was a faculty member at the residency program where I was a resident. And so we connected there. And then we met Aiden because we submitted similar talk proposals to SAM 2 years ago, right before COVID, and they connected us, which was great. That made the talk better. So that's how we all connected. And now we're connected.
Very cool.
Brought together by SAM.
Yeah.
I had one thing I wanted to add real quick before we go is I strongly recommend that the emergency physicians and others on this call try as much as you can to hear the voices of transgender and gender diverse people from their own voices. If you go on most streaming services, I'm not going to name any commercials, but if you go on a streaming service and you just kind of search for transgender documentaries, you'll find there's many, many options out there. I think the more time, don't listen to just one, like listen to a few different ones so you hear different perspectives. But as you hear people explaining to you their own life and their own viewpoint, it'll really help fill in and you'll feel much more comfortable when you're helping these patients.
That is so great. That is so helpful. Thank you. Thank you to all three of you. This has been a great, great session. I think we're past the time, so I have to say farewell.
Thanks so much.
Thanks, everyone.
Thank you.